Good morning, and from Mount Sinai Cath Labs in New York City, and good day anywhere you may be around the world at different time zones. We have the pleasure to present to you from our structural heart catheterization laboratories today a transcatheter aortic valve replacement case that will be led very shortly by our team in the catheterization laboratory, Dr. Sharma, Dr. Kinney, Dr. Kovacic, and co-workers. Just let me take a moment to give you a few housekeeping instructions from the get-go. First of all, you can view any parts of the transmission of today that you may miss because you may interrupt the viewing. Or same way that you can view any of our previous transmissions in the archives of this same website. If you can view the archive on your computer, right there, we host the previous cases, including the blog that follows after each case with any questions or answers that you post and we answer. And we're going to follow the same thing today. I also want to let you know that the registration is now open for this year's CC-VVC Symposium, Complex Coronary, Valvular and Vascular Cases Symposium here at Mount Sinai in June, and specifically June 14 to 16 here on site, with a lot of live cases and the chance obviously to meet and interact with all of us or all our faculty here at Mount Sinai on site. Ask questions and obviously view the cases and discuss the latest scientific advances in these areas of very important areas of interventional cardiology and structural heart disease. The next broadcast following this one for structural cases will be April 12th at the same time around the world, or 9 a.m. Eastern Standard Time if you are nearby to us in the United States time zone. In case you have any question during the transmission, please email us at info@structuralheartlivecases.org. I'm going to say that again, it's a bit long. It's info@structuralheartlivecases.org. It's a very simple email, however, and I will be introducing your questions through the moderation, or we would be commenting on them as the case flow. And again, thank you for viewing around the world. And let's go now to the catheterization laboratories number 6, hybrid room, to meet our operating team.
All right. Okay. Good morning, everyone. I mean, from New York. Could be somewhere, maybe everybody's on the screen here. Starting with Dr. Kinney on my left side and Jason Kovacic in the back. And on the right side, Dr. Stelger and my fellow Assad. We are ready for our case number 9 of the Structure Live, which we do every other month. 8 cases, this will be the 8th TAVR case. One we did a septal ablation. And of course, majority, this whole field, as I discussed last year, in my last year, of course, in the December webcast, the TAVR is moving very rapidly. In the sense, we don't know exact number, but looks like there are 50,000 plus TAVR were done in United States last year. And now the more detailed, it's a little bit, looks like the SAPIEN about 60% and 35% CoreValve and about 5% research trial cases. But clearly this field is evolving, emerging, and particularly within few months after the other trial results of the intermediate may explode further. And as everybody knows that the FDA has given permission to both Edward and nearly about to the Medtronic to do the low-risk TAVR trial, patient with a low STS gradient of less than 3, randomizing them to TAVR versus surgery. With that note, we start our today's case. This is the support. Of course, basic support here is by Medtronic and of course Bard and Terumo. Next. These are our individual conflicts. Next. So this is the 86-year-old patient who has progressive exertional dyspnea class 2 as well as stable angina. He has various CAD history with a moderate CAD, good medical therapy. What most important, had last catheterized was in August of 2014. We have moderate the 3-vessel disease with pulmonary hypertension, severe AS. And the question at that time was whether should go for combine surgery plus cabbage, or should be randomized to some other trials. And so the patient was reluctant. So after just about 18 months, 17, 18 months later, had more symptoms and brought here for the workup. And now, of course, his most important two factors. One is the lung point of view, COPD has progressed to about 60% FEV1, makes it moderate, and more frailty puts him in a high risk. Next. And we'll go through the individual points for this particular case determined to be a high risk for surgical AVR with STS risk mortality, although 4.4, but because of the COPD and frailty. Next individual, the echo. So we'll ask Partho to talk about the actual echo. Of course, this patient, as you can see, very high mean gradient with a valve area of 0.5. And Partho now comment on anything unusual besides very, very severe aortic stenosis.
Thank you, Dr. Sharma. So the team back here, I would like to introduce them, is my fellow Ben Hirsch, and also we have the anesthesia team of Dr. Ron Khan and Natalie Smith. So what we are doing today is this patient is undergoing the TAVR under conscious sedation, and therefore the patient is what is being done is we are performing a transesophageal echo under conscious sedation. Wow. So there is no endotracheal intubation. The patient is very relaxed, has been well sedated, and is tolerating the transesophageal probe. And the probe that we are using is the pediatric probe because it's half the size of the adult probe. At the same time, we are able to get adequate image, and this is really useful for the base of the aorta and the peri-aortic complex, which is much better visualized using transesophageal echocardiography. What you see here is the long axis view, and you can immediately appreciate that the leaflet motions are restricted. This is the right coronary cusp, this is the non-coronary cusp, and the patient has marked turbulence, so there is a lot of gradient, a lot of turbulence, severe aortic stenosis. There is also mild to moderate aortic regurgitation, but more importantly, you can start seeing that there is calcific nodules on the non-coronary cusp. There is moderate calcification, but there is a very interesting spicule that is formed at the base of the non-coronary cusp, and this will be important because when they are dilating and inflating with the balloon, this has the tendency sometimes to indent, and you have to look into the aortic root and make sure that there is no aortic root damage when this is being done. This is a short axis view. You can see here the calcification, which is more profound in the non-coronary cusp. This is a tri-leaflet valve, markedly restricted leaflet motion. There is also presence of mild to moderate mitral regurgitation. Importantly, also you can see there's a little bit of septal bulge. So the LV outflow region is a little crowded. The septum measures about 16 millimeter, but there is no evidence of subaortic obstruction, no systolic interior motion, and there is adequate room here for the valve to land. So this is also an important landmark to be defined in this particular case. Again, a closer look, you can see here the septum is encroaching into the LV outflow region, and sometimes this can displace the balloon or the device, and if this information is useful for the interventional team to know about. Obviously, the LV outflow region does not show any evidence of obstruction. And you can see here also the aortic root. There is some aortic atheroma, and this we're going to continue to monitor. There are no mobile plaques. And this is the advantage of the transesophageal. This cannot be obtained using transthoracic. Many places now we perform the TAVR under conscious sedation under transthoracic approach, but this is the information. This is completely difficult to obtain using transthoracic approach. So conscious sedation, T provides this incremental information. And of course, what we have also done is we have looked into the LV outflow region. You can see here the LV outflow region, the area where the annulus is lying, is very elliptical. So the long axis diameter we got from echo was about 21 millimeter. The short axis was 21 millimeter by 26 millimeter, and you will get the CT dimensions subsequently. So these are the information, a good LV function, but one more information, the LV is markedly hypertrophied, and the LV cavity is slightly small, so the wire has chances of getting trapped. So that will be another information to look into when the BAV and the other.
Yeah, a lot of LVH indeed, Partho, is very, very remarkable in this view, and the mixed disease explains why the patient presents with a velocity well over 5 meters per second. Very well.
Yeah, now actually, when you want to comment on this septal bulge now, which is becoming more and more in a discussion, we have done a handful of cases because Partho said it's a big septal bulge and valve will not stay, will be ejected out in the aorta. So we had combined them with the septal ablation, and 1 month or 2 months later, then did a TAVR. Because this case did have some septal bulge, but apparently was not encroaching.
I'm going to get Partho also comment on that. Depending on what do you think should be the thickness of the basal septal area before we consider. One definitely is that they should have an outflow tract gradient, which we see if it's more than 40 gradient different than the AS that we have done septal ablation before we do the TAVR. But in a situation like this where there is a septal hypertrophy, what do you think we should base it on, the thickness of the septum?
Yes, I think the more important is there any outflow obstruction or a tendency of SAM? And we have done both the cases we did, alcohol ablation, both had outflow obstruction in addition. So those were clearly important. Now, anecdotally, going back, we have had a couple of cases where the valve has tendency to move, and what we found was if you have more than 50% of the outflow occupied by the septum, so independent of the size of the septum, it becomes a problem, because then there is a bigger chance of the valve or the balloon moving and causing inadequate placement of the. But that is an area of active investigation. I don't think there is any cutoff value. But what we have done, and the cases both had outflow obstruction in addition to aortic stenosis.
And I have another case scheduled that with today. Okay, if we can go back to our slide, continuation of presentation. So now next, the aortic annulus, and I'll ask now Jason to talk about our CT measurements, because all CTs are carefully evaluated and studied by him, and make the recommendation in terms of the approach as well as the exact valve size, which I will discuss in my discussion today, which will be the need for pacemaker after the TAVR, that the accurate valve sizing is important for both, not only for preventing paravalvular leak, but also decreasing the incidence of permanent pacemaker.
Thanks, Dr. Sharma. Good morning, everybody. So you can see here the annular measurements. We're right across the annular plane on CT. We're getting a minimum axis of about 22 millimeters, and the long axis of this annulus is about 28, giving us a mean of about 25, a little over 25 millimeters. And this will be important if we have to post-dilate this valve, because that mean of those axis measurements dictates the size of our post-dilation balloon, around 25 millimeters. Perimeter is somewhere between 78 to 80 millimeters in an area of around 4.9 centimeters squared. And you can also note in that annulus, there's no large spicules of calcium. There is certainly calcification of the valvular leaflet apparatus, but the annulus itself has only mild calcification around it. Next slide. You can see there the annular angle, 38 degrees, very reasonable, not an horizontal lie. So this should be technically fairly straightforward from that point of view. Next slide. You can see there the sinus of Valsalva. We've measured in the 3 different planes. A mean is of about 33.4, which again is fairly generous. And now you can see there in some of the leaflet tips, some of the calcification. Sinotubular junction height is very generous again, 24 millimeters. And the ascending aortic width is around 29 millimeters, all appropriate for this valve. Next slide. You can see here the coronary ostia height, very important to make sure we're not going to occlude any coronary ostia. We like to see them above about 12 millimeters, and here again, very generous proportions, around 15 to 16 millimeters, both the left and the right. So we shouldn't be concerned in this case about coronary occlusion. Next slide. Here's our axis. You can see very, very mild tortuosity. I wouldn't call it tortuosity, just mild sort of curvature of the vessels. A little bit of spotty calcification down there in the common femorals on the right, more so than the left, and some aortic calcification also. Next slide. You can see here the dimensions of the, first the common iliac vessels, a little bit over 1 centimeter, and the external iliacs around, again, 1 centimeter, both sides. Next slide. And you can see here at the common femoral access point, again, around 8 millimeters. There was a little more calcification and disease on the right side, so we elected to actually access the left side. Next slide. So you can see here, if we put all the measurements together for the annular diameter, the annular perimeter, sinus of Valsalva height, and so on, you can see that the size of this patient's annulus and aortic anatomy entirely falls in within the range of the 29 millimeter Evolut valve, somewhat towards the upper end of the window for this valve, but still comfortably within by all measurements. Next slide. Good, and there you can see the 29 millimeter Evolut valve that we'll be implanting today. Next. Good.
You want to show that?
So just go to the live Cine images now, please,
we'll
and
come
we'll just
back
show you
in
the
1 minute.
access. So here you can see this has already been done so far. We access the right side, and this is going to be the non-access side. You can see there's a little bit of disease just below where the stick is there, but a generous vessel. What we then did is we went up and over the iliac bifurcation. So you can see there's a wire now going down the left common femoral, which goes right down to the popliteal on the left side. And we've accessed the left side. They're fairly high, done deliberately because there was a little bit of calcification, a little bit lower. We've then obtained our root shots. You can see here we've nicely lined up the 3 cusps of the aortic valve and all in the same plane. We've then put the pigtail into the non-coronary cusp. This will be how we'll be implanting and deploying the valve. And then finally, an interesting point that arose during our preparation. This is a standard part of the Evolut implantation, is we have to check that we have actually correctly seated the paddles into the paddle pockets of the valve. And if you look at this picture, you can see on the left-hand side of your screen, that the paddle to the left is actually sitting up a little more laterally than the paddle on the right. So this is probably okay, but we're really concerned if it's sitting higher and the valve is actually misaligned or bent a little bit. But nonetheless, we decided to refix this valve, to actually reseat it. And this is the final seating here. Now you can see the paddles are very symmetric, and that paddle on the left side is actually sat down nicely within the pocket.
Yeah, very clear. We see that at the very bottom of the screen, right side of the screen, at the bottom side, yeah.
Good. So just to the final summary slide.
Yes.
Back to the slides, please.
So therefore, now actually the point comes from Dr. Stelzer here. This case was determined as to be a high risk for surgical EVR. Now, and this is appropriate for TAVR. Paul, you want to comment on it?
Well, I think more and more we're looking at these patients from the standpoint of what would make this hard for this patient to get over open heart surgery. And pulmonary disease is high on our list. These patients are very difficult to get over the insult of general anesthesia with a pump run, even if it's short. There are patients who are going to struggle. Patients who are obese, patients who are frail, who have difficulty with arthritis, all sorts of reasons why you can't get them up and walk. These are the patients that I say, hey, come on, let's do the proven technology of the TAVR on these patients and not subject them to that increased risk of open heart surgery.
Actually, there was one sub-analysis based on the COPD and lung disease from patients in the partner trial, both high risk as well as inoperable group. And they clearly found that actually TAVR even had a higher mortality in those patients in 1 month.
Even TAVR?
Yeah, but of course it cashed up a little later. But overall, there was no difference in mortality once your COPD get to the severe. So therefore, these are the which we call it a futile cases. So don't do TAVR in those cases. And that is what the recommendation of ACCHA, our valve guidelines, that if you think patient not going to live 1 year, so the TAVR should not be performed, whether for whatever reason, clearly one of them being cancer.
Right.
Second is the COPD. Bad COPD with FEV1 less than 50, defined as a severe COPD. Those patients just don't do well for 1 year. So now we are done. If we can go back to our live.
Show the hemodynamics.
The hemodynamics, just show the hemodynamics, very severe gradient, exactly the same, mean about 60 we found, yeah, right there. And we have crossed the valve with the AR2.
What do you want?
Yeah, AR2 into the ventricle.
It looks okay.
It's in the front in the papillary muscle. This patient has a small ventricular cavity and very hypertrophied papillary muscles. So right now the catheter is landed up in the region between the papillary muscle and the left ventricle wall and will be required to be repositioned.
Okay. So this is a very important point here, that you got to go. We crossed it with actually AR2, whatever catheter that you use to cross, whether you are using the Amplatz catheter or just a regular JR catheter to cross, and then you go with the exchange length wire, go with the pigtail, reposition the pigtail, and then go with your extra stiff wire before you go with even the valvuloplasty or you're doing the TAVR directly.
The catheter is the wire is well positioned right now.
It's okay?
It's
Yes.
positioned okay?
Yes, it's in apex
Then?
right now.
We have to now exchange
Still
to
we have
the
to go
extra
to the
strip.
stiff yeah. But this step is very important because that anytime we try to cut this, we pay the penalty of a cardiac perforation. So this step has to be very clear with the echo guidance that your wire is nicely free, is taking a round at the apex. Good. We'll bring the other one. This is okay. He said position is good. Okay. Now here. Now we bring the X-ray on the main and the echo on the other side. Yeah.
Clearly, very nice repositioning now, exercise of the wire. So the position of the wire would support the very, I would say, as central as possible position of the valve during the release
This is 22.
procedure.
Okay.
This is very important.
So now the minimal access was 22, and so we are doing a balloon valvuloplasty. In this case, with such a high gradient, I think some people may, there's some push going on that avoid the pre-dilatation, but this is not the case where you'll avoid the pre-dilatation. You have to dilate this valve because with such a narrowing, the even TAVR valve may not go. So this is the 22 millimeter ZMAT 2. Okay, good.
Okay.
Ready?
Yeah.
Okay, pull back a little bit. It's too far down.
Okay. Yeah. Go up.
Okay. Advance a little
So
bit.
as you saw, the balloon moved a little
Yeah,
bit.
yeah.
No, that is because
Good.
he did it before it was completely
Good.
capturing. Okay, stop.
But that's
Stop pacing.
Yeah. Off pacing. Good.
Yeah, you did.
I think it's still, it was still around the valve. Yes, indeed,
Yes.
as Anu said, that the full balloon inflation occurred before the pacemaker had a full
Yeah.
capture. Actually, there is a little bit of a lag time between the capture of the pacemaker electrically
and the drop of the pressure.
and the appropriate drop of the pressure that has to go below 50. And if you respond to the electrical and not to the blood pressure effect, then there is a couple of seconds mismatch, and this way worked, moved minimally really, but a very effective dilation.
Remove the shield, it's quite
So
caudal.
the aortic regurgitation is unchanged.
Okay.
Okay.
We need to push the blood pressure a little bit. And
It's quite caudal, this one.
Want to go quarter?
It's quite caudal, yeah. It's 19 caudal.
Oh, yeah.
So we're going to go towards the implantation view now, which was the areocaudal, interestingly. Most of the time it's the AP or slightly LAO-caudal, but in this particular case, the valve was well positioned in the areocaudal. And the valve took very nicely the shape of the aorta and advanced in the LV
I think
easily.
Is it too magnified?
good one left.
It's
yeah.
a bit too magnified.
We're doing it.
Yeah.
Okay, good.
What do you think?
I'm going in a little bit.
Okay.
Advance the wire. Becomes a little coaxial.
Yeah.
No.
Wire is okay.
More.
No, wire is all right now.
Okay.
Wire is fine.
I'm
Yeah.
going cine.
Wire is in a great
Inject.
position, and
I think it
the
will go
marker
down.
of the
stay.
the marker that the
Yeah,
Boston
start
radiopac
releasing.
marker is in a
Yeah.
is not circular, it's a line, so this is a perfectly aligned valve, and it start releasing a little bit the bottom part until
Yeah,
it
yeah.
flares.
Okay, start pacing. Okay, so far so good. Keep releasing. Yeah.
Okay, we're now
Yeah.
fully
That's good.
released,
I
and
think
we
you're
have
good,
to
you're
wait
good.
now until
Cine
we
again, stop pacing.
see the pressure.
Okay, looking good. Release.
I think it looks okay.
Looks
Yeah.
good, yes.
Take the. Yep.
Yeah.
Yep.
Just pull the wire
I
back.
think you
yes,
come
yes,
out.
yes, center the nice,
Advance
yeah.
the wire.
Yeah.
That's it. No, pull it back.
Yep.
No, that's
Okay.
Okay, coming out.
Yeah, everything was performed in a very fast and expert fashion. As you see here, the valve was positioned exactly, and the projection was exactly the right one. You see that we can see the cross section of the valve perfectly here.
Hey, 1 second. Pigtail came back.
Okay, so the hemodynamics patient tolerated quite well. need to come in now. Yeah, you're doing it good.
Yeah. So there is a paravalvular regurgitation. We can see here. You can see here that it's mild to
Okay.
moderate
Ready?
at least. So there is under expansion on the septal side, and I think there will be an expansion required.
Okay, inject. Okay, good. Nicely positioned.
25.
Depth is very good.
Yeah, leave it there. But we need to dilate with a 25 millimeter.
Yep. So as you remember, the axes were 22 by 29, with the mean was slightly over 25. So we're going now with a 25 millimeter balloon, which is still just below the mean of the two axes of this annulus.
So you can see on the echo that the side where the septum is, on that side, the valve is slightly underexpanded.
Yes.
And there's the paravalvular regurgitation happening from that area.
Yeah, go.
Echo we appreciated by the cath looks perfectly expanded. Probably in another view might be a little constricted, but the depth of implantation is excellent. I think
Yes.
will allow a very safe post dilation.
Yes. Correct.
The septum gets really big.
Yes, it's currently there is a small area of under expansion which I think
180, okay?
Yeah, a
can
little
be
bit more
taken
in,
care
I
of.
think.
Okay, pace at 180.
So this is the 25 millimeter ZMAD.
Okay, go.
Okay.
This is very important. You have to make sure your blood pressure is less than 40. Even if you're pacing, it's fully captured. Blood pressure is less than 40 before you inflate. Continue pacing. Deflate the balloon.
Yeah, you have to continue the
Yeah.
pacing here. The pacing run
back
from
to
before
60.
you start inflating until the balloon is out of the LV right now. And as you see, they continue pace. The pressure recovers. You don't want to recover the pressure while the balloon is still in the within the valve, as the whole system may move.
What's the blood pressure? Yep. So just wait for the blood pressure to come up and then give the final. I think it looks expanded and the leakage is much less. I think I saw only a mild. There is
the
still a
pressure.
small area of gap that.
At the septum.
So you will
Yeah,
you will
didn't
see a
expand as
paravalvular
such.
regurgitation.
You didn't go all your pressure.
It's very high velocity.
So the question
jet,
is that
so it's
we'll go
small.
with the hemodynamics and
We are direct
this is still a mild to moderate, just over mild.
out of the
paravalvular.
I don't know if it's mild to moderate, Partha. I think you're a little bit too strict. I think it's a mild
If it was
PVL.
if it was more moderate, reasonable, but
Let's look at the hemodynamic screen, please.
Diastolic was 40 before we started. Where are we now? Okay.
Well, probably around 50.
No, that
Yeah,
way is
almost,
okay.
yeah,
Means
that
there
way
is no
that's it.
gradient.
No gradient, but
No
diastolic
gradient.
improved.
Diastolic pressure is about 54 maybe, and the
Yeah.
LVDP is about, I don't know,
EDP
25.
is just about the same, 22.
Yeah, it was between 22 and 25, and you can see a nice separation of the two. I don't think there is any criteria for a significant AI here.
By hemodynamics, no. Let's do the aortogram.
Now take out the pigtail.
Yeah.
Okay, ready?
yep.
Okay, inject. Okay, looks good.
And angiographically also mild. So hemodynamics mild, angiographic mild, echo mild. So it's all three for mild. Great position, great result.
The Partha, you are happy with
Yes.
the.
Yeah, I think overall,
Where you are now?
the septum, we know that septum
It's
is,
almost down.
it was a little bit of an issue, but I think this is a good valve implantation and overall a good hemodynamic result.
And because it looks like it's just 6 millimeter below.
Yeah,
from the
yeah,
tap.
4 to 6 millimeter below, that's a good depth, particularly a little higher, the septum may push high. So I think you need that little depth there to anchor well.
Okay, now while just to complete our the part of the discussion, we go back to the slide while Jason is putting the pre-close and the vascular access. Next, we have spoken about this the Evolut-R and of course the right alignment. Next, so basically what I'm going to talk today next is about predictors of the permanent pacemaker need and heart blocks and of course the TAVR outcomes. Next, now clearly it's next the very complex pathological structure of the AV node, the left bundle, the bundle of His, which are all near the aortic valve, tricuspid valve and coronary sinus. Next, and it actually have shown that that clearly that your left bundle during our procedures get distorted. So more inferior, and particularly the picture on the right side with the core valve, the more depth into the ventricle, it has a more chances to compress the bundle branch block of the left bundle. As you know, that no matter what you do, even surgery, they with a good technique, that they still have about 3 to 4% chance of permanent pacemaker after the surgical aortic valve replacement. Now part of that is because of the suture, some edema and so forth, so it occurs. And of course what we have seen with the TAVR, that number is higher, whether it's a 1.5 times higher with the Edward Sapien or it is 4 times higher with the core valve. Now maybe I'll ask Dr. Stelzer to comment on any surgical techniques which will decrease, and I'll talk about the percutaneous one, surgical techniques which will decrease the need for permanent pacemaker after aortic valve replacement.
Well, it's always a good question. When we're looking at the membranous septum, it's always possible to put our stitches in places that are avoiding that. However, calcification doesn't respect anything. So calcification can extend right down into the membranous septum, take out one or both bundles. And if we remove that calcium, then that may aggravate the situation with edema following the procedure. But in general, if there's not calcium directly in the area of the conduction system, we can keep our stitches away from it because we stay up in the annular plane. The TAVR has to sit below that in order to be below the nadir of the leaflet, where we follow the leaflets up into the commissures and can avoid that surgically. But it's a fine line. There's only a few millimeters difference.
Go back to slide, and that is exactly what this slide depicts. That membranous septum, which is the green, and the left bundle on the one picture is yellow, and other side and the extreme is the green. But the key is that if you avoid the membranous septum and you just above the annular plane, and that's what surgery does compared to the TAVR, it has to be on the that septal leaflets, so that septum, and that really cause the conduction issues and of course the heart block. Next. Now, first the paper which was really looked into this issue, that whether patients who have permanent pacemaker before the TAVR or those who require pacemaker after the TAVR, and of course those who do not, what are the impact. Next. And basically the very interesting, as you see, that about the 3 group of patients, 207 without permanent pacemaker, and then they compared with the 98 patients who require pacemaker after the TAVR and 48 patients who had a pacemaker before. So therefore it's a pacemaker before, second pacemaker did not require after TAVR, and pacemaker required after TAVR. Next. And basically clearly when do we need the pacemaker occurs in first 1 to 2 days and 3 days maximum. This is what the usual story is, and we learned that many of these cases you should do a pacemaker same day, because one of the issue has been those who develop pacemaker has a longer hospitalization, because by the time you make the decision and so forth. Though in some cases which are where it is predicted, it makes sense that do the pacemaker at the same time, and we start doing it now in about few % of cases. But clearly that you can have a need for pacemaker after the TAVR even later on. Next. Beyond your first 2-3 days. But very important finding. The important finding basically is whether you have no pacemaker green, prior pacemaker blue, and post pacemaker red, that as far as the short term up to 1 year, there was no difference in mortality. So whether you needed pacemaker or not, it required more prolonged hospitalization. There was also rehospitalization was higher, but there was no difference in mortality in this group of patients. So very reassuring. And other way around, some people felt that maybe the pacemaker, particularly with the core valve, higher pacemaker may protect them, maybe immunity would cause lower mortality in these patients, but that's not true also. So pacemaker does not change the overall mortality at 1 year. Next. Then clearly, this is basically the conclusion was that permanent pacemaker implantation does not seem to affect clinical outcomes adversely among patients undergoing transfemoral TAVI. Next. Now then, we have the meta-analysis paper by Dr. Siontis few years ago. Next. And they basically went through all the studies, 41 eligible studies came up with the various predictors. Next. And basically found that as of the important ones, as you can see here, older age, more important, male. You say, well, why male? Maybe because of the larger annular size, and then of course, atrial fibrillation, any kind of heart block correlate with the subsequent need for pacemaker. And of course, right bundle tremendously than left bundle, obviously so, because left bundle already have that issue. And of course, the Medtronic core valve, as you can see here, associated with higher pacemaker need. Next. And then they have an individual for Medtronic core valve. Next. And also for the Sapien. But by and large, these remains the factor. And so. And then one of them being the larger annular size. Next. Now then these are the various other studies which have looked into the both during surgery or during TAVR, that development of pacemaker or no pacemaker, various incidents and subsequent outcome. And clearly, overall message is that pacemaker does not increase mortality. It does increase prolong the hospitalization and increase the rehospitalization. The latest being in the Edward group by NYHA. Next. And that is all from the partner trial as well as the registry. Next. And they basically showed two other new factors came up. And one of them was the LVED diameter, left ventricular interstitial diameter, probably same. The larger annulus, larger diameter, higher need for pacemaker, and is the prosthesis LVOT, that you have bigger prosthesis for your outflow tract. So, or you can call it a valve annulus ratio, more than 1.1 is associated with higher need for pacemaker. Why? Because you are stretching it further. And clearly you are impinging on the left bundle branch block. Next. Left bundle, so causing the block. So therefore, they did have slight trend, I would say, higher mortality patients who require pacemaker. But this is just the one study, but majority of them remained identical. Yes, repeat hospitalization is more, as I mentioned, but overall mortality issue remains the same. So the various factors which we have spoken. Next. And clearly came up with the larger annulus also associated, that larger valve compared to annulus associated with the higher need for pacemaker. Next. Now, does putting a pacemaker, some people say, well, maybe you improve the ejection fraction in these patients, because many of these pacemakers had their AICD features and dual chambers and so, but there was no difference in ejection fraction. So that you need for pacemaker does not change your ejection fraction, does not change your mortality, increase hospitalization and rehospitalization. Next. Now there is another, the meta-analysis showing the large number. The overall pacemaker rate was 15% in 37,000 TAVR, and from various trials with a 6.5 in Edward Sapien and Medtronic 22.5. Next, and the 1 year, 30-day and 1 year mortality was no different. So overall, the consistent message which we have learned from various studies and meta-analysis. Next. So now the question is, we are using now the Sapien 3. There are some studies have shown now the Sapien, when Edward Sapien used to have 6% or so need for pacemaker, with the Sapien 3 is no longer true. It becomes 10 to 12% in Sapien 3 registry trial. Next. In this study, they actually had, next, 16% incidence of pacemaker of the 208 patients. Next. And clearly, that implantation depth and prosthesis oversizing were associated with the higher rate of new pacemaker. So clearly, the depth, oversizing, which are the procedure-related factor, very important. Just like in this particular case, you have right sizing, right depth will give rise to a less need for pacemaker. Next. So this is the three triangles which we want to put it together with the patient factors, the EKG factors and procedure. EKG we can't do anything about, right? Bundle branch block, any of those hemi blocks and all will have a higher pacemaker rate. Then age-wise, one we know gender, male, higher. Then of course the LVOT diameter and came up with a left ventricular end diastolic diameter. Both are associated with higher need for pacemaker. And of course mitral annular calcification, because the whole system is more calcified. More important is from our side, the procedural factors we can modify, important being that implantation depth, balloon pre-dilatation, process to annulus size ratio. These three important things which we can modify, and of course the studies have shown that transfemoral have a higher pacemaker rate compared to transapical, maybe because of accurate depth implantation. And lastly, which we know the CoreValve having a higher compared to Edward Sapien. And as you saw that with the Sapien 3, the advantage with the additional skirt decreasing the paravalvular leak. Now the whole issue of trading off with a pacemaker has been eliminated, because now the pacemaker incidence is much higher, is at 12 to 16% in the Sapien 3 trial, and we know with the CoreValve trial it's about 20-22%. Next. So therefore, if I sum up, that heart blocks and need for permanent pacemaker after TAVR is not uncommon, occurs in 4 to 22% of cases, and I would say by and large it is still, even in the low group of 6 to 8%, the 1.5 times higher than what we noted for surgery with a surgical valve replacement. And it can be predicted by various patient and device related and procedural factors. And this is a very important point, that we can predict these cases, so that if you know patient going to develop complete heart block, you better do a pacemaker at the time of your TAVR and decrease the length of stay, because those patients, you know, by 60-70% time you can predict will need a pacemaker, so better do a pacemaker at the same time. However, overall permanent pacemaker implantation is not associated with adverse prognosis on mortality, but is associated with a longer and repeat hospitalization. The second and very important point is here, next, and that is this issue of the permanent pacemaker need after TAVR will be of bigger concern when TAVR being implanted in younger patients, in a low and intermediate risk. That's where the TAVR is evolving. So clearly it will be a very big factor. You put a pacemaker in a 52-year-old, it's a big issue for that particular patient. So this, a particular TAVR device associated with a lower permanent pacemaker need may then be preferred in this risk group. We know that in the elderly it doesn't make a difference, but in a younger age, clearly this will be a major factor in terms of decision making. But turning out to be that while we are trying to take care of the paravalvular leak, that we are trading off the higher need for pacemaker, whether the better device or accurate. Now we still have to wait for the Evolut-R data. There seems to be Evolut-R having a lower pacemaker need compared to CoreValve, as you can see, I think largely because of the implantation depth which we have and some of the change in the stent design. So studies are Evolut-R about 16% compared to 22% with the CoreValve. And if you talk about the Sapien having 12 to 16%, so that becomes the new standard of the pacemaker after the TAVR. Okay, next we go to our 3 questions. Following statement about need for permanent pacemaker after TAVR are true, except means which one is the wrong answer. One is the overall incidence of pacemaker is 4 to 22%. Permanent pacemaker need after CoreValve is 3 to 4 times higher than Sapien valve. Permanent pacemaker after TAVR is associated with higher mortality versus no pacemaker. And lastly, the Sapien 3 valve is associated with higher permanent pacemaker rate compared to Edward Sapien valve. Next. Second question. Following factors are associated with higher need for permanent pacemaker after TAVR: female sex, large valve to annulus ratio, implant depth, and BAV. Third question. Following procedural factors can result in lower need for permanent pacemaker after TAVR, except TAVR device to annulus size of 1.1, 1:1, shorter implant depth in LV cavity, transfemoral versus transapical approach, and avoidance of balloon pre-dilatation. These are all questions based on the data which I presented. Next, so I'll give the answer. The first one was that statement about need for permanent pacemaker. Answer is C, that permanent pacemaker is not associated with higher mortality. Next. Second is the higher need for permanent pacemaker. Clearly the A, because the male have higher pacemaker need compared to female. And third is the lower need for permanent pacemaker after TAVR. Answer is C again, because transfemoral has a higher pacemaker rate compared to apical or subclavian. Okay, with that note, JK, where we are?
Yeah, let's look at the closure now.
Good. If you just go back to the live images, please. I'll just back it up here. Okay, so that was our final implantation shot. So the first thing we've done here to get the sheath out is we've backed the 18 French sheath out to the external iliac. You can see we have a sheath up there on the right side, which is a 6 French sheath, which is on a wire, which is a V18 wire, which is going up across the iliac bifurcation there and down into the to the left leg. So this shot, obviously a DSA shot, making sure we've got no perforation, no problem, no dissection. You can see here, particularly on the left side, the distal aorta, the common iliac on the left, no problems whatsoever. So then we've advanced that sheath from the right side up and over, down into the left common iliac. We've further retracted the 18 French sheath on the left side, and we're doing a second DSA shot now down into the more distal external iliac on the left. Again, no perforation, no problems. Looking good so far. We still have a wire up the left side and up and over from the right side. Next, we've actually deployed now the pre-closed sutures. We've actually taken the 18 French sheath out. And you can see here we've got early good hemostasis, a little bit of a minor pinch there at the axial entry point. You can see we've still got both wires up if there was a problem, if we need to go either ipsilateral or contralateral, but no problems whatsoever. A little balloon inflation. This was a 7040 balloon right at the access point. We've actually fully deployed and cinched down the pre-closed sutures and cut the sutures. Here's a shot now after the balloon, looking very good there. We've then pulled the wire, pulled the balloon, final shot, looks pretty good to me.
Beautiful.
And now we're out.
All right.
Yeah, this is a great result and a very good closure. You see there's no pinching of the branches or any other problem. Everything looks good, particularly the distal flow. We had a couple of questions regarding the pacemaker during the transmission, but I think the nice slide set presented by Dr. Sharma answered all of those in a most concise way. And again, the video of this broadcast will be posted later this week in the website under archives, so you can also see our previous webcast with structural heart cases. The next webcast is going to be on April 12th, at the same time, around 9 o'clock Eastern Standard Time, if you're in this time zone in New York versus anywhere else you are, same time you saw today, again on April the 12th. The live coronary, complex coronary, valvular and structural cases symposium will be held here on site at Mount Sinai, June 14 to 16. And the registration is now open at cccsymposium.org, 3Cs, cccsymposium.org, and you can get more details about the program and get a chance to actually register for this very interactive symposium we hold with very many live cases as usual every year. I'd like to thank Dr. Sharma, Dr. Kini, Dr. Kovacic, Dr. Stelzer,
yes,
or the fellows and nurses, the technicians, the technologists, the valve representatives, and the entire team. So many people in the anesthesiologists in the back area, as well as the echocardiographers, who always help us reposition the wire no matter what. Have a great time and a great result. So long from New York.
All right. Thank you. 10 o'clock.